Welcome everybody. Welcome to the COVID-19 Sunshine Coast update webinar, co-hosted by the PHN and the Sunshine Coast Hospital and Health Service. My name is John Harper. I'm very excited about this evening. We've got a great panel of experts who are going to present to us, and we want to make this as sort of interactive as possible. So I hope you're sitting comfortably. You've got a glass of wine within easy reach. Now, to save on bandwidth, I'm actually going to turn my camera off now, but you should still be able to hear my voice. And here we go. So firstly, some webinar housekeeping. All attendees are automatically on mute, but you can type any questions and comments using the chat box at the bottom of the sidebar on the right-hand side of your screen. And we will be collating common questions and comments from the chat box as we go through this evening. And then we will ask the panel to respond to some of those questions at the end of all the presentations. So do write your questions in the chat box. And I would firstly like to acknowledge the traditional custodians of the land on which we are meeting and recognise their continuing connection to land, waters and the community. And I pay my respects to them and their cultures and to their elders, both past and present. I would like to introduce our panel for this evening. So we have Dr. Rosie Muller, who's the Director of the Public Health Unit on the Sunshine Coast. We have Dr. Chris Lilly, who is the Acting Executive Director of Medical Services for the Hospital and Health Service, although he will be leaving that role very soon, but it's we're very grateful to have him hang on a little bit longer to be with us tonight. Dr. Kiet Chung, who's the Director of Infectious Diseases at the Hospital and Health Service, and Dr. Roger Fate, the President of the Sunshine Coast Local Medical Association and local GP. Each panel member will give a short presentation. And so first up, we have Dr. Rosie Muller. So if you can unmute yourself, Rosie, and we'll get on with the presentation.
Thank you, John, and thanks everyone for joining the webinar tonight. I thought I'd just start with talking to you a bit about the role of the Public Health Unit and what we've been doing with the COVID response on the Sunshine Coast. So largely our role is around disease surveillance. We receive case notifications for the Sunshine Coast HHS region. And a big part of what we've been doing is the initial contact with the case and case investigation to try and identify where the person has been exposed to coronavirus. The other part of our work really has been contact tracing. So once we've done that initial case contact, we're trying to identify all the close contacts that that person has had within their infectious period. And now we know that the infectious period can start up to 48 hours before the onset of symptoms. So that's the time frame that we're looking back at to identify close contacts. We've grown a large contact tracing officer team over the last few months. Our team has had to grow quite exponentially, actually, to undertake this level of intense contact tracing. As we move forward, I think our role will change a little bit, and what I anticipate might happen over the next few months is that we might start to see clusters of coronavirus cases, and the Public Health Unit then will have a big role in investigating and managing any clusters or outbreaks that do occur in settings. And the high-risk settings would be aged care facilities, particularly health services, workplaces and schools. Will be other settings that we may need to mount responses for. Our team of environmental health officers have also had a key role in the issuing of isolation notices to cases and quarantine notices to return travellers and to close contacts of cases. So the environmental health officers are authorised by the Department of Health to serve these notices, and then we have an obligation also to ensure that people are complying with their notices. So following people up to make sure they're adhering to quarantine and isolation is part of our role. I think the other key part of our role, as with any public health event, is providing communication and advice, both to the hospital and health service facilities, but also to the community, to the public and to community organisations, including the primary healthcare network, general practices, aged care facilities. Thank you. Just to give you an update of what's been happening on the Sunshine Coast with our coronavirus cases, we've had 92 cases confirmed to date, and that figure is current as of today. The good news is we haven't had any new cases confirmed since the 13th of April, so we're now past 2 weeks since we've had a case here. As of yesterday, 8 of those cases were still being actively monitored, 83 recovered, and we've had 1 death on the Sunshine Coast, which was back in March. So as I said, we've had no positive test results for new cases in the past fortnight, which is really fantastic, and Queensland had no new cases reported in the past 24 hours today. When we look at who's being affected, on the Sunshine Coast, our median age for cases has been similar to the national median age, which is 50 years. Most of the cases have been well and have been managed at home by the virtual ward, and the vast majority of them have been in return travellers from overseas. We've also had some cases in travellers who've returned from interstate more recently. To this date, we don't have any evidence of ongoing local transmission on the Sunshine Coast, and our numbers of cases where we haven't been able to identify a confirmed source are similar to the statewide numbers, around 4% of cases where we haven't been able to identify where they've picked up the illness. You probably will have heard talk about the effective reproduction number in the media. So this is the average number of secondary cases that will arise from a primary case. And nationally, this is sitting pretty close to 1 at the moment. So 1 case is expected to transmit illness to 1 other person. And this is really important. As long as this number stays at 1 or below 1, we're not going to see an increase in the number of cases. So that's the number to watch closely. If we look at Queensland cases over the last month, the red bars in the epicurve show you how we've had a steadily declining number of cases, and now, most recently, we're just getting fairly sparse cases with a few cases each day, and there's been a number of days where we've had no new cases in Queensland. The white line shows you the cumulative count of cases, and this is showing the flattened curve that we've luckily been experiencing now over the past few weeks. So similarly, this graph is showing the curve since the 1st of March for Queensland. So you can see that really the peak in cases was around the middle to the end of March, and things have really stabilised now. I just wanted to draw your attention to the Queensland Health website. So this link at the bottom of the slide provides daily updated data for Queensland with various different graphs, but also tables of the number of cases broken down now by local government area. So for the Sunshine Coast, if you go onto this website, you'll be able to see the number of cases for the Gympie local government area, for Noosa, and for Sunshine Coast. And there's a bit more information there as well as to what the source of infection was for these cases, the number of deaths. So it's a really good website, to stay up to date with our local data. I recommend checking that every now and then. And then my final, the next slide shows some breakdown of the age and gender of cases in Queensland. We don't have this level of data at a local level for the Sunshine Coast, but our age and gender breakdown would be pretty similar to the statewide picture. So what you can see here is that females slightly outnumber males, and the greatest number of cases are occurring in the 20 to 29-year-old age group. So this is total number of cases, it's not the rate. I don't have data on the different rates for different age groups at the moment. The final slide is really to show you some national level data that's available on the Commonwealth Department of Health website, and this is updated fairly regularly as well, not on a daily basis, but it does have a lot of good information there and different pictorial representations of breakdown by age group and source of infection. So that's just another good website to go to if you're wanting to stay up to date. Thanks, John. That's all I had for my presentation. Thank you.
Great, thanks very much, Rosie. If you do have any questions for Dr. Muller, do write them down in the chat box, which is down at the bottom of the right-hand side of that sidebar. Next up, we have Dr. Chris Lilly, who's going to be talking about the service changes at the SEHHS. Thanks, Chris.
Thanks, John. And based on the fact that I don't have a PowerPoint presentation, would you rather my mugshot on the screen? I'll leave it to you to decide.
Yeah, do you want to just try that and see if the internet will cope?
So there we go. Hopefully people can see me. Thank you very much for the invitation tonight. As John has already highlighted, I'm the outgoing EDMS. I've sat in the role for the last 3 months, and I would say that it's been the greatest experience of imposter syndrome that I've ever experienced in my life. For those of you who are familiar with my clinical work, my roles generally are as a child and adolescent psychiatrist, and I'm currently the clinical service director for the mental health service on the Sunshine Coast. And in February, in fact on February the 3rd, I on invitation of our current chief executive was asked to sit in the role of the EDMS about the time that people started getting very excited about COVID-19. And I have to say that the consequence of that is I've had the most amazing learning experience for 3 months, but certainly I'm very proud of the opportunity I've had to help lead a very committed group of clinicians, both within the hospital but outside the hospital as well. And I'm absolutely delighted that we're using the initiatives of COVID-19 to be running things like the webinar tonight. And it would be very much my hope and intention to continue these processes in the long run. When COVID has long since been and gone, I'd like to think that this will be a great opportunity for us to work together. I suspect that many of the questions that will come tonight may well be related to service, but there were a few things that I wanted to highlight. First of all, we've got an amazing facility on the Sunshine Coast. We obviously have a number of hospitals, but we've got the Sunshine Coast University Hospital, which has been engineered to manage pandemics in ways that none of us quite understood, but credits to the people that designed the building. We have a massive capacity and engineering built into the building to allow us to do things like scaling up negative pressure rooms, both within the hospital ward environment, but also, for example, within the operating theatre environment. So in a COVID surge situation, we can still reasonably safely run normal operating theatre practices without contaminating corridors and so on. As Rosie has highlighted, as I finished in the role on Friday last week, we were sitting on about 10 days, I think, of no new cases on the Sunshine Coast. And much of the challenge that now exists for us is to think about how we restore normal principles of healthcare to an environment that obviously still is at some risk related to COVID-19, but making sure that things that we've turned off very quickly, we think about how we can turn them back on. I'm sure many of you will be aware that there's been a considerable widening of testing criteria, and I'm sure Keir and various others may well talk about this as part of their discussion, but in an attempt to try to determine opportunity for community spread. Now people with almost any respiratory condition can have or respiratory symptoms can have testing done. And in fact, over the weekend, we've seen our fever clinics at Caloundra and at Gympie seeing again a bit of an increase in presentations. We were talking last week about our fever clinics, and for people to understand, we have them running at the Caloundra campus, at SCU, at Gympie and at Nambour. And last week we were wondering whether we needed to keep all 4 open. We would have kept in principle the clinical activity of a fever clinic, but whether we needed to maintain a separate building within or a separate room within the building was up for debate. And I think reflecting the fact that for a number of days we were getting very few people presenting, but as we open up the opportunity for people to move around a bit more, and the Chief Health Officer's initiative of increasing people's social travel, inevitably we will see pockets of community spread, and we'll need to be able to respond to those fairly quickly. So being able to scale up and scale back our fever clinics is going to be an important component moving into the future for us. I know some of the questions already coming through are about what's happening in our outpatient clinics and elective surgery. Again, Department of Health's initiative in the last week was to very quickly start thinking about how we could restore some of the outpatient activity and the elective surgery activity. And on Monday this week, we were able to start back with some of the Category 2 outpatients and the ultra long stay cases that were on our list. In fact, we were doing a very good job of working through. When I first started in February, it was looking like by the end of the financial year, we would have eradicated all of our ultra long stays for outpatients. They've obviously been banking up as we stopped a lot of that activity. Similarly, we are increasing elective surgery this week and opening more and more theatres and increasing the number of lists based on what has been our #1 concern throughout the last couple of months, which was making sure that we could maintain a reliable supply chain of protective equipment, personal protective equipment. And as it currently stands, Queensland is in a reasonably good position. I think the Sunshine Coast is in a particularly good position as far as PPE is concerned, but that is in no reason other than having established a PPE working party that's been able to use all of the clever algorithms and database systems to make sure that we can readily anticipate rates of use and the supply chain entry of PPE back into the healthcare environment, and based on that determine how much work can take place. And on the Sunshine Coast, we've been in a good position. At other HHSs in Brisbane, for example, determination about how they were going to work the following day was dependent on arrival of PPE on the night before. We haven't been at that stage, which is good, but clearly the issue of PPE is very important for yourselves and certainly incredibly important for us. The Category 3 outpatient, I guess I use the word rejection of referrals, has created a lot of tension for all of us. It was a hastily but necessarily made decision by Department of Health that we would stop our outpatient activity, partly to reduce the attendance of people with lower levels of illness within the healthcare setting, but also to allow us to deploy our nursing and medical staff who otherwise would be involved in those environments to other alternate settings. And I know Rosie's already mentioned the army of people that we've had doing and will continue to do contact tracing as is necessary. So a lot of our dental staff, for example, our ENT staff and others have been involved in contact tracing, a very important clinical skill that can be taught, however, requiring manpower to be able to achieve it. And so redeploying people from within our health service to those important environments was one of the things that we had to do. And the price that we paid for that is people with the Category 3 outpatient needs are being referred back, if you like, to a general practice environment. And I've had a number of concerned emails in the last week or two asking about where the governance for that sits. And it is still, I think, it's probably clear, but it's an unpalatable situation that it sits squarely with general practice. And I think that for us is something that we would need to collaborate on to understand. And indeed, in an environment where we're starting to increase activity, one will imagine that the natural impact will be that category 3 outpatients will probably restart in the reasonably near future, but I guess hasn't been announced at this point in time, and maybe then that will give some confidence back to most of the environment. The final thing that I wanted to mention was the external recruitment that we've been engaged in. So, of course, there's been expressions of interest at a state level. Most of the people, I think, if we think about absolute numbers, have demonstrated that they're prepared to come back and work within a Queensland Health setting. However, their preference would not to be working in a rural and remote environment, and that creates great tensions within a health service that or a health setting that has to provide good levels of healthcare, not just to the Sunshine Coast and Brisbane, but also to Longreach and further afield. So the commitment that we've made is that we will very readily take up expressions of interest where required. If people have indicated that they're only prepared to work close to their Southeast Queensland base, what we will almost certainly be doing is we will take people into the HHSs in Southeast Queensland, and we've had a very good commitment from within our health service of our staff who are prepared to go and work in rural and remote settings. So I think we will be reasonably confident that we can keep most healthcare working within most of those environments. And obviously an outbreak of COVID-19 in a small rural hospital would potentially be devastating. And I guess in the same way as we've seen SWAT teams moving into Tasmania and otherwise, one will think that that's a possibility that happens within Queensland. The final point I wanted to make on that is I very much appreciate the generosity of people who've locally indicated a wish to return to work within a Queensland Health setting. We've been very carefully making sure that we can scale up and scale down that workforce as required. Very well aware that a month or so ago we were concerned that we might have devastating impacts of our own staff becoming sick and a need to be able to bring staff in to replace them. Of course, that's not the environment that we're in currently, but that doesn't mean that it can't happen again at some stage in the future. As it stands at the moment, we probably have enough staff working within our own health service to provide for the needs that we have. However, we have been working very hard in the background to get scope of practice credentialing completed for people who've indicated a wish to work with us, and you would be drawn upon if the need arose. So I think I'll stop there, and in due course happy to answer any questions that come from that. Thank you.
Great, thanks, Chris. Next up we have Dr. Kier Chung, the Director of Infectious Diseases. Thanks, Kier. If you want to unmute yourself.
Yep, thank you. Thanks, John. And thanks everyone for inviting me to talk today. So next slide. So look, I'm going to briefly talk about testing and a bit about infection control and PPE, and just a quick slide on the management of COVID-19, both with what we're doing locally and I guess some of the things that people might have seen on the news. Next slide, thanks. So just a reminder, so COVID-19 is caused by SARS-CoV-2, which is one of a group of family of common respiratory viruses, which 7 viruses cause disease in humans. Three being a bit more infamous, including the current problem, as well as SARS and MERS. And we all know the story about the zoonotic transmission of these types of viruses. Next slide. So testing criteria has been mentioned a couple of times, and I think this probably leads on to some of the questions we've had. And I guess this has been one of the challenges, at least from my point of view, from an infectious disease point of view, I've had over the last 4 months, 3 or 4 months, has been the rapidly changing recommendations of whom we should test. So currently, the testing criteria involve clinical and epidemiological criteria. And currently, the clinical criteria include anyone who's got a fever or acute respiratory infections. And then they either have to have certain epidemiological criteria, which are the ones we've all kind of heard about in terms of travel, cruise ships, healthcare workers, or from high-risk areas. But of importance is this group of hospitalized patients with no other clinical focus of infection. So I think one of the questions had been about, whether we're testing the right group of patients, right groups of the community, and we're missing cases. And Rosie's already said that we don't believe that there's any evidence of local sustaining community transmission. And we've been testing hospitalized patients with no risk factors with fever and respiratory symptoms for probably maybe up to close to 6 weeks now. And the feeling is that if we were to have problems with community transmission, we'd start to see those infections coming from this group of people with acute respiratory infections. And certainly we've had no unexpected patients in this group who've come positive on the Sunshine Coast. Next slide, please. The other thing that's happened over the last maybe 4 days now is the Chief Health Officer recently announced an expansion of the testing. And just as an example how rapidly this test, I did this slide maybe yesterday morning, I think it was, and has already changed this afternoon. So the Chief Health Officer has recommended that we should test anyone in Queensland with fever or respiratory symptoms, regardless of any other risk factors. One of the concerns that was raised, at least at our HHS and other HHSs, was the impact of testing people who've got other clear diagnoses. So, for example, someone who comes in with clear bundle cellulitis, who has a fever. There were some of these groups of patients were being tested over the weekend. This has now been clarified to be in line with the public health guidelines, which was in the slide before, that these patients should only need to be tested if should they have a fever or respiratory symptoms without any other clear source. So a fever in someone with cellulitis, doesn't necessarily need to be tested unless there's other concerns for COVID-19. Next slide. So we've tested over 90,000 people in Queensland. I think it's quite a lot higher now. This was from the weekend. And the primary way we should be diagnosing people is with a PCR. And that's either with upper respiratory tract samples. We recommend both a single swab for the throat and nose, or if patients are in hospital, or lower respiratory tract samples. There've been the reasons for the changes of the testing criteria over time relate to Queensland Health testing capabilities when we were trying to focus our resources on high-risk groups. That's certainly been increased significantly, and testing capabilities is actually going to be expanded outside of the Brisbane labs. In fact, at the Sunshine Coast, at the SCU lab, we will be getting on-site testing hopefully around in 2 to 4 weeks' time, which will certainly decrease our turnaround time significantly. QML and SNN have the capacity to test, and I have limited capacity to take swabs as well. Other methods for diagnosis that are reported are viral culture, but certainly this is not readily available, and is only available in certain centres. I've mentioned serology here because there was a rapid antibody test that was highly publicised in the media. We now do have a serological assay available at Queensland Health, which has been validated. But it's important to remember that serological tests are not useful for the acute diagnosis of a COVID-19. They probably do have a role, but definitely not in the acute setting. Perhaps their role may be in the investigation of outbreaks to determine the extent of it, and perhaps later on in the future when population studies are done. As we all know, it can take up to 7 to 14 days for antibodies to develop. So it's not a recommended test for acute diagnosis of COVID-19. Just a couple of slides on infection control. So the main things that I've been trying to reinforce is that standard precautions are still extremely important. This includes things like hand hygiene and cough etiquette. When looking after patients or managing patients with COVID-19, either suspected or confirmed, for the majority of patients, contact and droplet precautions are appropriate. So that consists of a flat surgical mask, eye protection, gloves and gown. And this includes the collection of nasopharyngeal swabs. So the collection of swabs is not an aerosol generating procedure and does not need airborne precautions. In certain groups of patients, the virus can be transmitted by airborne routes, although certainly the droplet route is the main method of transmission. And this group of patients are those that are critically ill, or those who are having aerosol generated procedures. And in those groups, we will substitute a surgical mask for an N95 mask, as well as the use of negative pressure rooms. But certainly in hospital, the less unwell patients we are managing in single rooms and reserving our negative pressure rooms for those that need them because of aerosol generated procedures or more severely unwell. Next slide, thanks. So look, management of COVID-19 is still predominantly supportive, and that, obviously that's relating to respiratory support. There's been lots of discussions about high flow oxygen, non-invasive ventilation and ECMO. I think the jury seems to flick back and forth about whether NIV is appropriate. I think increasing experience from overseas has suggested that NIV may be appropriate, but there are significant infection control considerations with high flow and NIV, and because these are highly aerosol generated procedures, and so need to be undertaken in the with the right precautions. There is still a push for early intubation for people who look like they're heading towards needing respiratory support, as intubation, managing someone on a ventilator is a lower infection control risk than on NIV or high flow oxygen. In terms of pharmacological therapy or medical therapy, there's no proven effective therapy at the moment, and we've all heard the stories about Plaquenil, Kaletra, Remdesivir, and then more recently tocilizumab, steroids, and there's been some stuff coming out of convalescent plasma, but certainly there's no good evidence for any of these at the moment. The recommendations from a number of professional societies, both the Australian Society of Infectious Diseases as well as our counterparts in America, is that these should really be undertaken in clinical trials. And we're certainly involved with at least one on the ward plus a couple in ICU at the Sunshine Coast University Hospital, although we've yet to enroll in on, as our case numbers, as Rosie has demonstrated, have decreased quite significantly. Next slide. So in terms of, I guess, local management, initially when this all started, we managed everyone as an inpatient, as the recommendation from the both federally and at state level was that all patients with COVID-19 should be managed in hospital. And bear in mind that 80% of patients have a mild disease, and that quickly became, I guess, difficult because of bed flow and resources. And then we developed processes to manage people either under hospital or the home if they needed additional nursing cares or support. But if they're very well, we now manage them on the COVID-19 virtual ward. And on the virtual ward, these patients are managed by either phone calls or telehealth by nurses, as well as GP support. And should there be any issues, their care can be escalated, usually to an inpatient setting for review. A number of inpatient units have been involved with the planning, but predominantly ICU, respiratory, and general medicine. Sorry, the second ICU should have been ID. And as Chris has kind of alluded to, we've done a lot of planning looking at patient flows, the management of patients on our wards and opening new wards up, as well as building capacity for DEM at ICU. Next slide. Oh, and that's all my slides, John.
Great, thanks very much, Kurt. I'm just going to give a little bit of an update now on the PHN activities relating to COVID-19. So the first thing I'll talk about is the PPE, the personal protective equipment. So the Commonwealth Department of Health has been distributing masks to PHNs. So we have been getting a combination of standard surgical masks and some P2/N95 masks. These are available to general practices who are unable to get their own supply from commercial suppliers. And it's simply a case of the practices filling out an online request form on the PHN website, and then those masks will be provided. And practices can continue to request those masks. There's not a limit on how many they request. If their needs are ongoing, then they can just simply fill out another form and request some more masks. What we're doing is then just passing on that need to the Commonwealth Department of Health, and they are managing the national stockpile, obviously in terms of distributing those masks out to the PHNs as well as to other healthcare facilities. So if there are GPs out there who really are in a bit of strife with getting masks, then do contact the PHN. We also have a list on our PHN website of commercial providers of masks and hand sanitizers. So do have a look at the PHN's website. There's a COVID-19 webpage which has lots of useful links, including information on commercial suppliers. The Commonwealth is also funding these respiratory clinics, which are in many ways have a very similar role to the Queensland Health fever clinics. So these are designed to assess and test COVID-19 suspects. And the idea is that in most cases, their existing general practices are being expanded and resourced to provide assessment and testing facilities. And these have been, we've got a couple in the Sunshine Coast region, and they should be coming online in the next couple of weeks, I hope, which will hopefully time well if there is a bit of an increase in testing requirements because of the because of the changes to the testing criteria. So we'll let you know. There'll be information coming out from the PHN when they're open in the Sunshine Coast region. We are also providing a free telehealth platform for GPs, specialists, allied health, and aged care providers. So this is the Health Direct video call software, which is a very straightforward, easy to use video calling program. It's web-based, so there's no big software downloads or anything like that. It's all done through a web browser. It is fairly straightforward for both patients and medical professionals to use. And all you have to do is just contact the PHN and then provide some information, some practice information, and all the providers, the doctors who will be using it, they need to register for the system, and then we'll get you up and running. Health Pathways. So many of you will know Health Pathways. It's a program that I head up on the Sunshine Coast. It's a website. It's a free resource for health professionals in the area. And it's really come into its own in the COVID-19 space because it allows us to very quickly update information. And it also provides a single source of truth for all sorts of information, such as testing criteria, which are changing all the time. We've developed a number of COVID-19 pathways within Health Pathways. As you can see here, there's one on practice management, which is really about adapting your practice to COVID-19, so infection control strategies, as well as telehealth and PPE and various other things that you can look at. There's the assessment and management page, which is really the nuts and bolts of how to deal with someone who you think may have COVID-19. Request and local processes, which includes the details and locations of the HHS fever clinics, and will include the details of the respiratory clinics, the Commonwealth-funded respiratory clinics. There's a page which just has all the links to the national and state resources. There's another page on impact on clinical care. So many of you have received emails from the RACGP and others and around changes we need to make in our clinical care because of COVID-19, such as avoiding use of nebulizers, etc. And there's a few of these that impact on a few parts of what we do. So there's a page there with all the guidance that's been collated from all the relevant colleges, etc. And then we have impact on local services. So as Chris was talking about, where changes have happened locally, where perhaps referrals are being dealt with differently, or other services are changing, that'll all be on those pages. if you don't have a Health Pathways login, then do contact the PHN. It's a very straightforward login, and you just save it into your browser, and then you can always have access to it. As I mentioned before, we have a very comprehensive COVID-19 webpage on the PHN website, which includes all the relevant links to the state and national websites, as well as useful succinct information on testing, etc., and information on getting those masks. And that's it from me. I'd just like to hand over now to Roger Fane. Thanks, Roger. Just unmute yourself, Roger. Just might need to unmute the microphone, Roger.
Can you hear me, John? Oh, here we go.
Oh, yes. Yep. There we are. Thank you, Roger.
Thank you. Thank you very much, John, and thank you to Chris Dilly for his hard work. And thank you for having me along tonight. I can't emphasise how important these representative meetings are in such a time of potential, very real Australian disaster. It's also very reassuring to see a mostly unified approach by medical experts, politicians and hospital management, locally, state and federally. This has been a unique time for Australia to show its ability to make rapid policy changes and take the public with them. One only has to look across the Pacific to illustrate what happens when politicians and medical experts don't form a team. Tonight is an example of our local health district emphasising the need to communicate with and update the local medical professionals. I'd like to thank Patty Hudson, the CEO of the Primary Health Network, and particularly Dr. John Harper, Senior Clinical Editor of the Primary Health Network, for the arduous task of updating the COVID-19 update on a twice-weekly basis at least. I recall contacting John in early March while I was working out west, asking for more detail, and it came. There's lots of detail published regarding the epidemiology and health risks of the coronavirus, particularly in the early days, and that's only 2 months ago, including the obvious differences between population centres, states and countries. Thankfully, the information avalanche is slowing and more organised. Also, the restriction of the provision of PPE is improving, as is the ability to test for the coronavirus. These issues are illustrative of a true disaster. I would like to thank our local hospital health district experts for their preparation and work towards preparing for a local epidemic, which may still arrive. Dr. Chris Dilly, retiring Acting Executive Director, Dr. Kurt Chung, Director of Infectious Diseases, and Rosie Muller, Director of Public Health. The work of providing expert advice can be arduous, and I thank them for their time and professionalism. Now, of course, doctors need to know when work will resume to normal, whatever that normality is. It's been announced that the restriction on elective surgeries is relaxing as of this week, however, with a long way to go. Many specialists will still be unable to operate for an effective income, as is operate in an operating theatre for an effective income for some time. There's likely to be Surgery Connect outsourcing, I'm sure. Telemedicine for the private sector will continue till the end of September. There will be a gradual, slow easing of restrictions, fortnight by fortnight, I imagine. And who knows, the LMA might soon be able to resume committee meetings, maybe even small clinic meetings. I now look forward to hearing from the experts. Thank you very much for having me along.
Thank you very much, Roger. That was great, and a great summing up of what's been happening. Now, this is the good bit. We get to throw some questions at the panel. So we've had quite a few great questions come in from the attendees as they registered, and there might be more coming up on the chat box as well. Firstly, I've just got a couple of questions just for Dr. Muller. So a question came in about the publication of reported positive cases. Could these be published by postcode rather than LGA or HHS district, or notifying practices when positive cases have been confirmed within the sort of the catchment of a or a postcode of a practice? Would that be possible?
Yeah, thanks, John. Look, it's a good question. Currently, with all notifiable diseases in Queensland, we only do have data published down to the local government area. So we don't have the capacity to publish data at a postcode level for any notifiable disease at the moment. So I don't anticipate that'll change for COVID. It's only just in the last week that we've had the data at local government level, so it's good to have that available to the public now. I guess some of the reasons around this, primarily around privacy and confidentiality, and you might be surprised by this, but it's true that in a place like the Sunshine Coast, where cases are identified in the media in a particular locality, confidentiality really is a big issue, and unfortunately this has been a problem for some of our early cases on the Sunshine Coast. So protection of privacy and confidentiality is one of the key reasons that data is not provided down to that very local level. As you can imagine, some communities are very small, and it can be quite easy to identify a person. So I guess the short answer is no. At the moment, we only have local government level information, and I suspect that will be as detailed as we will get. Thank you.
Great, thanks, Rosie. There's another question that maybe Kit might be able to answer. So this is about PPE, and with the testing for COVID-19 now being broadened significantly, GPs are potentially going to be seeing a lot of patients with some respiratory symptoms. As you mentioned in your presentation, we're sort of thinking that the numbers within the community are pretty low because the numbers at the sharp end in the hospital are low. And so most of these people who we're seeing will be low risk. So what sort of attitude should we be having within general practice in terms of using PPE for these patients? And what is realistic given the numbers we might potentially see, and just some guidance for yourself on the sort of risk assessment, I guess, in terms of how we protect ourselves as practitioners, as well as our waiting rooms, etc.
Yeah, look, it's hard, and I'm clearly well aware that there have been some general practices have had some difficulties accessing PPE in a I guess a consistent way, but I guess the whole reason for increasing the testing is trying to look for cases, and so I guess we're still concerned that we will eventually have this whole second wave that people describe, and that may be from, well, that's likely to be, I think, from community cases. So I think we still need to be using the PPE that we think is appropriate for managing these patients when we test them. But there are other things that can be done in terms, I think you comment about waiting rooms. So actions like social distancing, depending on mask availability. If patients wear surgical masks, that certainly does significantly reduce their risk of transmitting the virus. And we've recently had a case within our HHS where that was a big part of how we manage the staff. But I guess from my point of view, I think my recommendation is that we do still need to be using the appropriate PPE when we're swabbing and having close contact with them. Patients who are not unwell with this droplet precautions, if we can remain social distancing, then that will significantly reduce the risk of transmission, as well as the amount of time we spend with the patient in the room and in a face-to-face situation. But so I think in summary, I don't think I can say that we should do anything different with our PPE when we think that this is the main PPE we need to use to protect ourselves from patients, because we don't know when case numbers will increase, so we won't know until afterwards, I guess, which is the whole idea of doing this testing.
Great, thanks, Kit. And I guess perhaps the onus is on us to look at our telephone triage when patients are making appointments, and just to make sure we're getting sort of a fairly full clinical history from them in terms of what their symptoms might be before they come into the building. Just a few more questions here. One sort of fairly specific one about elective procedures. When is a COVID patient cleared for having an elective procedure? Is there a standard waiting time before they're allowed to have an elective procedure?
I guess, you know, the patients who are diagnosed with COVID-19 have to meet specific criteria to be able to be released from isolation, and that's something else that has changed quite significantly over the last few months. And so currently the ability for someone to be released from isolation, so i.e. be deemed non-infectious, relates to being a certain time out of time from the onset of illness. So depending on if they've been in hospital or not, maybe 10 days from after onset of illness, or 10 days from the start of when the test was taken, if they've been asymptomatic, as well as having no symptoms for 72 hours. Those patients who would meet that criteria, who are required to have a medical procedure, you know, can do so without any issues. Patients who are quarantined, who are isolated, who are positive, can still have medical procedures if it's if it's necessary, and it can't be delayed. So I think, you know, we have done procedures on patients who have been positive, who've been still infectious, but obviously we have to take in the hospital and in theatre we would use our COVID theatres and and use airborne precautions for intubation and procedures. But all these release from isolation, that's all guided by both ID as well as the public health unit, and the virtual clinic and HIF and our inpatient services have specific, I guess, specific communication methods to make sure that's all done to the right criterion. The other group of patients are those who work in a high-risk environment. And by that I mean either aged care facilities, or healthcare workers, or school, or educational settings, or such as schools. And if there's a few others, but this group of patients actually require swabs to be cleared before they can go back to work. They can be cleared and released from isolation and still adhere to social distancing, but before they can go to that high-risk environment, because of the potential significance of getting it wrong, those patients are required to be swabbed to be cleared.
Great, thank you for that. There's another question around the sort of the procedure or the processing for testing and fever clinics, etc. I might just answer this one. There's lots of information on health pathways about this too, but I guess there are a couple of ways of going about this. You can obviously, if you want to do the swabs within your practice, you can invite the patient into the practice, don the PPE and do the swabs, and then send them off to the lab. Or you can do a phone call with the patient, telehealth consultation, and ask if the patient's not unwell or not too unwell. You can send them to a private pathology lab and fax the pathology form to the lab, and then just ask them to go to the appropriate location, and all the locations are on the Asylum Nicolaides and QML websites. You'll see they've got specific COVID testing locations. And then the other option is that you could send them to a Queensland Health Fever Clinic. They do not need a referral to go to a fever clinic. I know that sometimes it is helpful if they do have a pathology form that has been emailed to them, because sometimes Queensland Health Fever Clinics do outsource the testing to a private provider, so I know that can be helpful. So there's sort of the three options available to you. If the patient is unwell and suspected of having COVID-19, then they obviously need to be going to the emergency department. All right, let's see if we've got, is there anyone else want to comment on those? Did I have everything right there? Chris, Rosie, does that sound about okay?
Just with the fever clinics are predominantly just, we now just sent into Queensland Health. We did try using the private labs initially, but the turnaround time was fairly long. And now that we've got lab capacity, we're using Queensland Health pretty much, 100% now.
Okay, great. So, and just another question on the swabs. So, we're taking the swabs. Should just the one swab be used for a nasopharyngeal collection and then a throat collection, or separate swabs for each location?
Yeah, no, one swab is adequate. So, throat, then nose. And look, the reason behind that was, once again, because of resourcing. So at the start, we were doing two swabs for that, and then they were getting another swab for all the standard respiratory viruses. But as with the COVID-19 created supply issues for the swabs, and so we now just recommend a single swab for both throat and nose.
And just some questions around the testing criteria. So if you see a patient, for example, with a sore throat, if looking like a typical tonsillitis, or for example, seeing a 1-year-old with a runny nose and a fever and a bit of a cough, should we be testing these people or not?
So it's Rosie. I can start with this one. I think it's still a difficult area, I think, is something to acknowledge. The Chief Health Officer of Queensland is now keen for pretty broad testing in the community. So, if someone does have a fever or does have acute respiratory symptoms and there's no obvious cause of the infection, then we would recommend testing. I think if it looks pretty typical of a strep throat, then you might decide not to test. There will be clinician judgment that comes into it. So unfortunately, it's not quite clear cut and black and white for us yet, but there definitely is the directive from the Chief Health Officer that she's encouraging broad testing where symptoms are present and where there's no other obvious cause for those symptoms.
I might just throw on the end of that a sort of general comment that I think everybody just needs to be incredibly tolerant with each other in this regard. And as Rosie has highlighted, criteria change almost day by day. Other principles upon care change day by day. The health services response changes almost day by day, and I'm sure there are features of general practice that probably change day by day. And I guess this is really completely consistent with a new illness that we're learning about and trying to make the best possible choices in that set of circumstances. And absolute credit goes to our Chief Health Officer, who I think has run a monumental campaign to date and appears to be guiding us to make the best possible choices on most occasions. So I'm sure there remains frustration, but I can tell you within the health service that's exactly the case as well. And we try to work with the information we have available to us and recognise that we have to be very agile at the moment.
So just for Rosie here again, just one other point to make as well is that the guidance is that anyone who is tested does need to remain isolated until you've got a negative result. So please do advise people that that's what they will need to do.
That's great, thank you. Just a comment here that the respiratory clinics that I mentioned, the one location is in Sippy Downs, at Oka Sippy Downs, and there's a comment here that will be opening this Friday, which is great, very timely. Another question about cytokine markers. So is there any place in clinical practice for cytokine markers, e.g. IL-6, as a predictor for early ventilation.
It's Keir here. Look, I've seen some of the stuff that's come out about that. There are some trials that have been, or some studies that are being done. It's certainly not routine clinical practice. Other people have also talked about, so some of my colleagues and overseas have talked when they've heard a lot more cases than we have early on, talked about, rising CRPs and falling lymphocyte counts as also being a marker, which probably falls in line with the whole inflammatory kind of process. But so it's essentially not routine clinical practice, I'd have to say at the moment.
Great, thanks very much. Well, it is 7:30. Anyone in the panel have anything else they wanted to say that they didn't have a chance to say before?
That's Rosie. I'd really just like to thank all of our general practice colleagues for all the work that you're doing out there, and recognise how difficult it is to be in your shoes at the moment. So thank you very much, and we really appreciate what you're doing.
I'd really like to mirror that comment as well. I very much appreciated the what feels like very close collaboration that we've enjoyed with each other in the last few weeks as we've been wading our way through a very difficult set of circumstances. And I'm very pleased to be handing over my my role to Dr. John Menzies, who comes to the Sunshine Coast, but I'm sure many of you are aware is on the board of your PHN, and he has clearly highlighted an intent to make sure that the positive liaison that at least this meeting represents continues long into the future. So thank you.
Yes, it's Roger here. I'd like to suggest that we look at having one of these every 1 or 2 months, particularly in these disaster times, as long as it doesn't put suck too much energy from our specialists and colleagues in the PHN.
No, these are
maybe I could just
great.
throw in. Sorry, John, I was just going to say as well, we have an army of people who, John, I'm sure will have indicated on the health pathways, but an army of our either specialists or registrars who are ready to answer questions if there are particular issues that happen by virtue of the displacement of category 3 cases back into a general practice environment. We worked with Michelle Johnson last couple of weeks to get together that group of people. So if you are feeling like you need the extra support, you should be able to find the person to call, and they should be ready, willing and able to assist you with that.
Yeah, thanks, Chris, for the reminder on that. So on Health Pathways, you'll find that there are advice pages for each specialty. So like gastroenterology advice, cardiology advice, and on those pages you should find phone numbers for the public hospitals to get you through to a clinician, a registrar or consultant who can provide some clinical advice in these times. So this is fantastic. I think this has been really, really good. It's so good having these questions coming in and being able to get the answers directly from the panel. I really hope we have more of these. I'm sure we will. I think it's these pandemics are awful things, but they do tend to speed up reforms in different areas, and it certainly makes big changes in health and communication, which I think has been for the better. So I'm quite happy about that. I would just like to thank all of our panel members. Thank you to Rosie Muller, Chris Lilly, Kiet Chung, and Roger Faint for their time this evening. You can go and have your dinner if you haven't had it already. Any questions that you've put in that haven't been answered, we will hang on to them and get them answered and emailed back to you. And just lastly, you should receive an email about an evaluation from the session. It's really helpful if you can answer the evaluation. None of us really like doing evaluation emails, but if you can, that would be fantastic. So thank you all very much for listening in tonight, and we hope you'll join in with the next one. Good night. Thanks very much.
Thank you.
Thank you.
Thank you.